So the session title is Bifurcation. We're going to start from evaluation to the optimization of a bifurcation. We've seen since morning we had left main bifurcation having double strength strategy, and just now ago we have like a discussion, should we go for a bifurcation or not? So this is like a deep dive, how to tackle bifurcations, irrespective if it's a left main or diagonal LAD or PDL. So we're going to start with Dr. Ziad Al-Ali. Dr. Ziad is the director of the METIS Cardiovascular Center in San Francis Hospital and Heart Center in the United States. And he's going to be talking today about the evaluation of bifurcation, starting from the site, the severity, and possible strategies.
Thank you very much. So it's a pleasure to be back in Dubai after a long hiatus, about 15 years. Of course, it's going to be impossible to summarize bifurcation PCI in the span of 12 minutes. So I'm going to summarize it, but also give you my opinions on it after synthesizing the data. The first question, of course, is does bifurcations really matter? Well, what we know is that about 18% of the all-comer population includes a bifurcation, whether or not you plan to stent it. And we know that if there's the presence of a bifurcation, the target vessel failure rates are higher. This is data from almost 13,000 patients, unselected from all of the randomized controlled trials of individual patient data we had at Cardiovascular Research Foundation. And you can see that there's a significant hazard of about 30% in terms of target vessel failure at 1 year. When we look at the list of the highest risk factors for target vessel failure, bifurcation PCI comes up very high on that list after only in-stent restenosis, CKD, moderate to severe calcification, and non-ST elevation myocardial infarction. So let's first talk about severity. Now, this is what most of us know as the labeling of bifurcation PCI. This is the Medina classification. And the Medina classification essentially classifies the presence of main branch or side branch vessel disease based on the location of the plaque. And while this is useful for clinical trials, I don't really think this is useful for clinical medicine. And the reason is these are the clinically relevant PCI or clinically relevant bifurcation lesions. That is the presence of atherosclerotic plaque in the side branch. How do you use and interpret this data to your advantage? So let's talk next a little bit about the site. I think this data is underrepresented and really been understudied. The most important factor in when you're performing a bifurcation PCI is the amount of myocardium at risk from the side branch. This study, which looks at the amount of myocardial mass as assessed by CCTA in grams and percent of the LV mass, shows us some incredibly important information. What it shows you is that the most important branches cover the most important territory. Hence, you can see that the proximal LAD, mid-LAD, proximal circumflex account for the vast majority of the myocardial mass. How do you interpret that in terms of a bifurcation? Well, what you have to think about is how much myocardium is covered by the side branch compared to the main branch. And what you see, of course, is if you look at the left main, the amount of functional myocardial mass is very large. So if you have the entire circumflex at risk from a bifurcation PCI, the data is very different to, for example, if you're treating a side branch such as an obtuse marginal. Let's study this a little bit. If you look at non-left main PCI, the percent of vessels with a functional myocardial mass greater than 10% is only 20% of all the cases. So this is really the only place where you could potentially gain a benefit from a second stent. So bring the bar down. Now, how many times have we inadvertently, or not understanding this data, gone ahead and done bifurcation PCI to the second diagonal? Look at the amount of mass covered by the second diagonal. It's almost zero. Right? Very, very few second diagonals cover functional myocardial mass that require a second stent. So if you're doing a two-stent strategy on a second diagonal, all you can do is hurt the patient and the artery. You can't gain a benefit. Similarly, look at the amount of myocardial mass that's covered by the PDA and the PL. Whereas The proximal circumflex, the first diagonal, the OM1 and the OM2 are targets that can actually benefit from a dedicated strategy. Hence, we should be using physiology to assess these intermediate lesions on a regular basis. Now, why is DK Crush 5 so different from the other studies? How is it possible that the provisional stent rate of events is almost double target vessel failure? The cardiac death rate is higher, the target vessel MI rate is higher, the TLR is higher, and the stent thrombosis is higher. Is this just an anomaly? Or does it have to do with the amount of myocardium at risk? Because as you remember, these patients are left main lesions. If we study the data, what we learn is that patients with a side branch length greater than 73 millimeters, patients with a left main bifurcation are the only predictors of a functional myocardial mass greater than 10%. So anytime you're performing a bifurcation PCI with a two-stent strategy, outside of these situations, you need to think very carefully about risk versus harm and really put into context what current available data there is. So let's talk a little bit about strategies. I think the European Bifurcation Club has really hammered home this concept of the provisional approach. And while they've done that, and I believe the evidence for that is largely supportive, what they haven't done is gone into the nuances of why. Why is provisional better? And I'm going to go back again to this concept of the functional myocardial mass. You can't really help an artery that doesn't cover enough mass to create an event for the patient. Now, the first thing we have to do is do no harm. So to do things like wire side branches to protect them is simple and basic fundamentals of PCI. It's simply not wiring a side branch greater than 2.5 millimeters during main branch PCI is like putting your child in a car without a seatbelt. It's totally unacceptable. It's risk for no benefit. So wiring both branches prevents plaque shift, it provides a marker for the side branch, and makes the angle favorable for rewiring the side branch. This is the EBC practical approach that's sort of currently pushed, and that is if you've got a large diameter vessel, a large territory of distribution, and a long lesion in the side branch, we should be considering elective two-stent strategy. But let's look at the data and the most contemporary data. This is data from 2022. Not surprisingly, mortality is not different between a complex strategy and a simple strategy. The reason is regular PCI doesn't do that, so why would we expect for a mortality benefit in bifurcation PCI? Target lesion revascularization is also not different comparing a provisional strategy to a two-stent strategy. You can see this is almost 3,500 patients. Meta-analysis for myocardial infarction. Again, the same situation. No benefit for provisional versus a two-stent strategy. And then again, no benefit for a two-stent strategy versus a provisional strategy for stent thrombosis. And this is really where the data comes for the EBC's recommendations to say, start off with a provisional approach in the vast majority of cases. Now, one of the areas where the EBC identified a potential benefit for a two-stent strategy is when you've got a side branch lesion length that's greater than 10 millimeters. When you put this into context with a large functional myocardial mass, which includes, for example, circumflex, obtuse marginal, and first diagonal, it starts to make sense as to where you could potentially get a benefit. Hence, to gain benefit from bifurcation PCI, the benefits have to outweigh the risks. And this is a practical approach that I like to teach my fellows. The true bifurcation, which means you have a greater than 70% stenosis in the main and the side branch, the vessel has to be large enough for you to actually be able to gain a benefit, and the length of that vessel has to cover enough myocardium for you to gain a benefit. The side branch disease has extend well beyond the ostium, and then we should be performing imaging-guided PCI of both the main branch and the side branch. Where's the evidence for that? If you look at the side branches that are greater than 2.5 millimeters, older data, which takes into account this, looks and shows us that a complex strategy may be beneficial. Again, going to the amount of myocardium at mass. Similarly, if you've got a side branch that's greater than 2.5 millimeters, a bifurcation PCI two-stent strategy actually helps you reduce the main vessel restenosis, and this is largely due to sizing and the pot technique. So in summary, if you take true bifurcations, i.e. vessels that have greater than 2.5 millimeter disease and have lesions in both the main branch and the side branch, you can reduce target vessel revascularization and main vessel restenosis with a two-stent strategy. What about the second part of the strategies? There's all these different techniques: culotte, tap, direct bifurcation stenting, dedicated bifurcation stent strategies, crushes, DK crush. How do we put all this context in data into context? This is a recent systematic review and meta-analysis, one that's published in JAHA. You can see that there's the largest amount of data is really for provisional stenting, tap, DK crush, and culotte. And what you'll notice is that there's really a very wide spread of these techniques. And so there really is not strong data to suggest that any one is beneficial than the other. You will notice, however, that DK crush is significantly swayed in terms of TLR, stent thrombosis, and DK crush, as well as major adverse cardiovascular events. That's largely because that hazard is driven by the DK crush study from China. So finally, if you are going to perform bifurcation strategy, what intravascular imaging should we use? This data, which was recently presented, the October study, focused on optimal lesion coverage, making sure that we didn't have malapposition, making sure that our stent was expanded, and leaving no unintended crushed or distorted stent segments. And there was a large benefit for an imaging-guided PCI in terms of major adverse cardiovascular events. The patient-oriented composite endpoint was also lower, and there was a trend appropriately in terms of reduction in each of the composites of the endpoint: all-cause death, cardiac death, target lesion myocardial infarction, and ischemia-driven target lesion revascularization. Importantly, and I'll finish off with this, the subgroup analyses showed that this benefit existed for both provisional stenting and was larger for provisional stenting than even side branch stenting, which shows that simply stenting across may not give you the same benefit as stenting across and using imaging guidance to ensure that you have an optimal pot as well as that you have an optimal minimal stent area. Thank you very much.
Thank you, Dr. Ziad. That was an excellent presentation. Now, in the past, we heard about dedicated bifurcating stent from the industry. Would that make a difference in our approach, where you minimize the amount of metal and not leaving any area not covered? For some reason, I heard about it during my fellowship, and it didn't make it to the market. Is there any insight from your side?
Yeah, so great question. So we were the largest enroller in the Triton study, and the major problem with the dedicated bifurcation stent was that it was not drug-coated. It was a bare metal stent. And so from a regulatory process to get that covered with drug became too complicated, and the company finally ended up sort of ceasing or stopping business. As you can see, this is a very complicated scenario. The data is really all over the place. Synthesizing the data, the take-home messages are: the best gear for a bifurcation is your brain. Okay? If you have a very large amount of myocardium at risk, particularly in the left main, the evidence suggests a benefit for a two-stent strategy, and that makes a lot of sense. What makes also perfect sense is if you're going to stent the second diagonal, right, the only thing you can do is harm it, because you can get a peri-procedural MI, you can get a stent thrombosis, but you don't have enough myocardium to reap any reward from it. And so we should use this functional myocardial mass data from CT to really help us understand that the areas that we should be focusing on for an optimal bifurcation strategy and outcome is the left main, the first diagonal, the obtuse marginals, and think very carefully about the PL and the PDA and suggest provisional might be the best approach, irrespective in that situation.
Thank you, Dr. Ali. We have, I think, a question from the Dr.